Hi, good evening, everybody. My name is Dr. Mushaffa Khan, Junior Resident in the Department of Radiodiagnosis, Dr. BVP Rural Medical College, Luni. My topic for today is Spectrum of Ovarian Cysts and Tumors, a Radiological Approach. My aims and objectives for today is to identify the presence of an adnexal or ovarian mass, to differentiate benign versus malignant masses based on sonographic morphology, to validate the sonographic criteria using histopathological confirmations, to aid in early diagnosis of ovarian malignancies, to detect malignant features at an early potentially curable stage, and to reduce the diagnostic delay and improve prognosis. Materials and methods. Place of studies, Department of Radiodiagnosis, Dr. BVP Rural Medical College, Luni. It is a retrospective descriptive case series. Inclusion criteria include patients with adnexal or ovarian masses detected on ultrasonography, patient cases with available histopathological confirmations, patients providing informed consent, patient who subsequently underwent surgical excision. Exclusion criteria include functional ovarian cyst resolving on follow-up, patients with isolated tubular ovarian masses, patients with incomplete imaging or histopathological data, patients not giving consent for the study. First category today is cystic lesions of the ovary. Physiological cyst. It is broadly classified into physiological cyst, functional, and other cyst. Physiological cysts include ovarian follicle and corpus luteum. They have a diameter of less than or equal to 3 cm. Functional cysts produce hormones. Follicular cyst of the ovary, which produces estrogen. Corpus luteal cyst produces progesterone. Theca lutein cyst seen in gestational trophoblastic disease. Complications that can undergo, then the functional cyst can undergo include hemorrhagic ovarian cyst, enlargement, rupture, or torsion. Other cysts include multiple ovarian cyst and ovarian hyperstimulation syndrome and polycystic ovaries. Neoplasms of the ovary include they are categorized on the basis of histopathological features into epithelial surface cell tumors, germ cell tumors, sex cord stromal tumors, and metastasis. Simple ovarian cyst. It is in the imaging features of simple ovarian cyst include it is anechoic, with no internal blood flow, thin and smooth walls, unilocular, can be intraovarian or exophytic, and shows posterior acoustic enhancement. Hemorrhagic ovarian cyst include they are usually it usually occurs when there is bleeding into a functional ovarian cyst, which is often a corpus luteum. They have more complex appearances due to the blood products, fibrin strands, and clots. They have a fishnet-like internal echos from the fibrin strands, diffuse low-level echos, no internal vascularity on color Doppler study, and they are thin-walled and they often resolve spontaneously within weeks. Hence, post-menstrual follow-up is given to these patients. First case for the today is a 46-year-old female came with chief complaints of PV bleeding since 2 months. In the first image, you can see a large multiloculated multicystic mass lesion noted in the pelvic region, predominantly in the right adnexa. In the second image, you can see the cystic lesions with internal septations. Histopath findings were confirmed to have the patient having mucinous cystadenoma. Mucinous cystadenoma is a benign ovarian tumor often appearing on ultrasound as a large multiloculated cystic mass with variable echogenicity due to its mucin content. Case 2 for today is a 36-year-old female with chief complaints of pain in lower abdomen and abdominal distension since 1 month. In the first image, you can see cystic areas containing numerous echogenic balls floating in an anechoic liquid. And the second image shows a transvaginal ultrasonography demonstrating a hyperechoic nodule within the cystic mass, Queria Rokitansky's nodule. Histopath findings were confirmed to be having dermoid cyst of the ovary. Dermoid cyst or the mature cystic ovarian teratomas are common benign ovarian neoplasms. These are slow-growing tumors which have they contain elements from all the three germ layers like ectodermal, mesodermal, and endodermal. On color Doppler study, dermoid cyst shows no internal vascularity. Case 3 for today is a 38-year-old female with chief complaint of pain in abdomen and irregular PV bleeding since 1 week. In the first image, you can see a large, well-defined anechoic, thin-walled cyst with clear fluid contents, no septations or calcifications of solid component noted within. In the second image, you can see a multiloculated anechoic cystic lesion with no solid areas and may sometimes show internal septations. Histopath findings were confirmed to be negative for malignancy, suggestive of serous cystadenoma. These are benign surface epithelial ovarian tumors commonly seen in women of reproductive age group and represent one of the most frequent benign ovarian neoplasms. On color Doppler study, it shows no internal vascularity too. Case 4 for today is a 78-year-old female with chief complaint of PV bleeding. First image shows a multilocular cystic solid mass in the left ovary. It shows a solid component within it and 1 to 2 small papillary projections. Second image shows that the internal solid component shows internal vascularity, and this patient's labs were confirmed to have a CA 125 level of more than 5,000 units per ml. Histopath findings were confirmed to have a high-grade papillary serous adenocarcinoma. These are the most aggressive, frequent type of ovarian epithelial cancers. They are ill-defined, complex, solid cystic ovarian masses with thick septations and show loss of normal ovarian contour. On color Doppler study, there is increased vascularity noted within the solid component and the papillary projections. Case 5 for today is a very interesting case of a 22-year-old female with chief complaint of irregular bleeding and pain in the abdomen. On the first image, we can see a heterogeneously hyperechoic solid cystic mass, predominantly solid natured lesion with poorly defined margins seen arising from the left head nexa. The lesion is seen displacing the uterus towards the right. The mass lesion is mildly displacing the bladder in upward direction with no bladder invasion. Color Doppler shows marked vascularity. Beta HCG levels were confirmed to have a value of 3,48,300 milli international units per ml. On histopath findings, it was confirmed to have a malignant germ cell tumor, non-gestational choriocarcinoma. The last image shows a post chemotherapy image, post 5 cycles of imaco regimen, and there was a significant reduction in the size of the tumor, almost half the size. So my conclusion for the study is ultrasound remains the primary modality, remains the first line imaging tool for assessing ovarian lesions due to its accessibility, cost effectiveness, and high diagnostic yield. And it is very important for morphological assessment. Systematic evaluation of lesion characteristics like size, wall, thickness, septations, papillary projections, internal echogenicity, and laterality is important. Color Doppler has a significant role in differentiating between benign and malignant lesions. Peripheral low resistance central flow, especially within the solid components of papillary projections, raises suspicion for malignancy. Identification of malignant indicators like solid components, thick irregular septate, ascites, and bilateral ovarian involvement indicates towards a malignant ovarian neoplasm. And always correlate with histopathological findings as it remains the gold standard. While imaging provides a reliable presumptive diagnosis, histopath remains a definitive, validating the accuracy of radiological assessment and helping refine the diagnostic criteria. Thank you.